face the camera. No? Better, I think.
So for aortic stenosis, especially TAVR is indicated. You think cardiac MRI will be better than 2D echo if the 2D echo person who does is not good?
No, I think that's not the point. No, I mean echo. Let's not get into who's good or bad. I think it's quite standardized. You know, if you get the plane right now, the machines are so advanced, they will only give you a report of, you know, how much is the stenosis, etc.
Yeah.
When a person is defined to be a candidate for TAVI or TAVER, then the next thing is a CT scan that is done using something called a TAVER protocol. So here a CT is done where in a specific way, where then measurements are taken of the valve area, of the veins, all kinds of things. We do it at our center. My colleague Parang Sangvi, he's the one who reads them. I don't even look at them, because I just don't find them of any interest, and he's developed an interest in that. So there's a specific protocol, specific reading, and every TAVI patient gets a CT done before for planning, not for diagnosis. Diagnosis is all on echo, and in the end, today all 90 to 95% of aortic stenosis is now TAVR. So, you know, that anyway the cardiologist is not going to touch unless they are 100% convinced that there is aortic stenosis. So that gets sorted out quite well.
So for students there who might not know what is TAVR or TAVI, aortic stenosis, if it becomes symptomatic, like syncope, angina or breathlessness, or aortic stenosis where the gradient across the aortic valve is very high, these patients are candidates for replacement of the aortic valve. And traditionally it was surgical aortic valve replacement or SAVR. Now there is it's a wind going, now transcatheter, you call it transcatheter aortic valve replacement, where a valve is introduced from the femoral, and it is lodged into the diseased valve. And so we are not technically replacing the old valve, we are implanting the new valve over the old valve, that is called TAVI or TAVER. So this procedure is done after an echo, and as I said, as a CT scan. Is it called a CT aortogram or something?
No, it's just called CT TAVER protocol.
CT TAVER
Don't
protocol.
Even bother.
And then they do this procedure, which maybe costs anything between 13 to 20 lakh rupees as a procedure. Okay. So you can come up here and ask. CT TAVER protocol, TAVR protocol.
I was done cardiac MRI for hypertrophic cardiomyopathy, and the criteria of ICD is 15% fibrosis. And mine was 25% under you had already done it. The thing is, in future, suppose fibrosis increases, ICD has been already inserted. How to know further progress of fibrosis in future? Whether it is remained 25 or it has gone further?
So we can do an MRI even though you have a pacemaker. That's not a problem anymore. So that's another thing. Huh? I still remember till about almost just 7 years ago, I have this talk that I give to other radiologists on contraindications of MRI, or sometimes even to non-radiologists, and we would say, you know, the only absolute contraindication to MRI is if you have an electromagnetic or electrical device which, if it stops in the MRI and potentially can kill you, then MRI is a contraindication. So to that would be pacemaker, because if the pacemaker stops and, you know, then your heart is pacemaker dependent, then you can die. And with cochlear implants, we used to say if it's better to be deaf than dead, then you have to do an MRI for cochlear, you know, any part of the body, and if the cochlear implants fail, then so be it. Everything's changed. All the cochlear implants now are MRs compatible. So unless you had a very old cochlear implant, it doesn't matter. Nobody bothers, nobody asks. You just do the MR. Pacemakers, every pacemaker is now MR compatible. So you can pretty much, you just have to call the technician who will make some adjustments in the transducer, and we do MRIs in everybody. The only challenge with having a pacemaker in the heart to do a heart MR, cardiac MR, is the artifacts from the catheter inside, which can sometimes mask the ability to see things. But every patient is different, and so unless we do your MRI, we will not know what and how bad the artifacts are. So if we have to see the extent of fibrosis, then we can do it. But the counter to the argument is that now even if the fibrosis increases, the only treatment to reduce your risk of sudden cardiac death is your ICD, which you already have. So how does it matter anymore whether the fibrosis is increasing or not? So there is no real reason to repeat an MRI in your case.
Thank you, sir.
Yeah.
So again, for clarity, whatever orthopedic implant you have is not a problem, pacemaker. Deep brain stimulation catheters in the brain are not a problem.
Okay, DBS, I would talk to the company and the neurosurgeon before
you,
doing
okay.
it. Yeah. I am not too sure. I think there's still one or two which are an issue.
Okay.
But aneurysm clips are not a problem. None of those are problems. There are new problems that have come up. Tattoos have become a problem. Some tattoos, you know, they produce heating. So then the patients complain ke bahut garam lag gyu tu.
After the contrast?
Just in the MRI. Because some of these inks have a little metal within them. So that is a problem. The second thing which has happened in some centers is where people have gone in saying we have nothing. So they wear sportswear. You know, your Lululemon and Athletica, all these very, you know, those tight yoga pants that have now become fashionable, and then you wear appropriate similar shirts. You see runners with them. Nike, Adidas, all of them they have these tiny silver filigree linings because that makes them sweat resistant and all that. Those heat up. We didn't know that. So now every MRI patient changes. It doesn't matter whether you're coming prepared, you know, without any metal in your body, you just have to change, because now the clothes, we don't know which clothes have a little bit of, you know, silver or metal work within them for all these things, you know, sweat absorbent, loose, breathable, stretchy. There's so many clothes now that have come up. So fabrics that have come up. So you have to be a little careful. The only other contraindication which we worry about is a metallic foreign body which can move. So gunshot injuries, they anyway come and tell you, but we still have to be a little careful. And any ocular foreign bodies, we are still a little careful. So we'll always do a CT scan first, see what they look like, and then decide if it's worth doing the MRI or not. Yeah.
Just to clarify, what he's saying is if there is a gunshot injury and there are those fragments of bullets lodged, say, within your liver or lung, during an MRI they can move and therefore cause some damage. Yes, sir, you can come up if you can.
Sir, what about dental fillings, metal caps and dental implants?
So if I'm doing an MRI of the brain and I have very bad dental implants and especially metal work, then the skull base area sometimes becomes very difficult to see. They are not a contraindication, But just 2 days ago, we had to stop the scan halfway because the girl said, I'm feeling a pulling sensation in my mouth. So once in a while that happens. It's not harmful, but if the person says that now I'm uncomfortable, then you have to stop the scan and obviously not do it. The same is also true of some metallic orthopedic implants. They are not a contraindication, but once in a couple of months you'll find a patient who says, मेरे को लग रहा है कि कुछ pulling sensation आ रहा है. If they say that, then we usually stop and we don't do it. But it all depends. But none of this is harmful.
Correct.
Yeah.
Some patients do also complain of heat generation.
Yeah. It's usually heat and pulling. Yeah, you're right. Correct.
We say that MRI is safe, there is no radiation in MRI, etc. Is there any side effect of MRI? Any side effect?
No.
Theorized? Nothing?
No. The only thing is because we don't know the effect on the fetus, because MRI is loud. For many years, there was this thing that don't do it in pregnant women unless absolutely required. But now we do MR for congenital anomalies, so now that is also gone. So theoretically, there's nothing. No.
Yeah. First you can come, Dr. Pankaj, and then...
I have two questions. In acute abdomen, you said that CT abdomen is the investigation of choice. Whether it's a plain or some contrast is
With
required.
contrast.
With contrast.
With
IV or oral?
So the question, just to repeat, is the CT scan done in acute abdomen, should it be plain or with contrast? It is always with IV contrast. Oral contrast, we would generally just use water as an oral contrast medium.
Sir, and why this ectopic pregnancy is not detected in...
It's just not. We can't see the ectopic focus. We know that the inflammation is in that area, but whether it is tubo-ovarian, acute, tubo-ovarian disease, or whether there's an ectopic, you can't. Their ultrasound will actually show you the live. CT is not real time, no? So even if I see something, I don't know whether that's a fetus, it has a beating heart, none of that. All that is with ultrasound.
So you wanted to come?
MRI for people who've had mitral valve replacement, the older ones, the metallic valves, can they?
No, yeah, not a problem.
Not?
No, not a problem.
Not a problem.
Not a problem. No.
Achha, regarding this CT abdomen, could you tell us when do we do plain, when do we do oral, when do we do IV contrast?
Okay. Yeah, that's a good question. So, plain scans today are only done when we're doing the CT KUB. That's it. All other indications would always have intravenous contrast. So that is sorted. Oral contrast, the reason why so earlier, up to 10 years ago, every patient would also get iodinated oral contrast. So your bowel loops become white and you can separate them from lymph nodes and other structures because the resolution in those days was not very good. In the last 10 years, in 90% of our CT abdomens, and especially if we're doing upper abdomen imaging for hepatobiliary, pancreatic lesions, etc., we have found that using water or negative contrast, so you just give 2 glasses of water and the bowel loops are kind of gray, and then you can actually see vessels, pancreas, gallbladder, CBD, stomach much better than with iodinated contrast. So the indication matters. If it's anything to do with pancreas, biliary tree, we will use only water. If it is for PUO, we will give iodinated contrast because we still want to see the mucosa of the bowel loop. So it all depends on why the patient has come to us. But plain scan is only KUB. All scans otherwise are with intravenous contrast. And oral contrast, the only question is, do you give water or do you give iodinated? That is a decision we make.
So one very important lesson for us is when we refer a patient, please give a history, a background history of the patient, details of what are you suspecting or what are the symptoms, so that they can make a better call on what kind of contrast to give. Or in any investigation, even X-ray chest, we don't write what is it for. I think the radiologist is disadvantaged by not getting the clinical background. And if they have the clinical background, they will make a better diagnosis even on a plain X-ray chest.
So I'll just add to this. As much as almost all CT scans of the abdomen and pelvis are done with intravenous contrast, except for a plain CT KUB, it's the reverse in the thorax. 80% of all CT scans in the thorax are plain scans because you don't really need IV contrast just to look at lymph nodes or differentiate lymph nodes from vessels. So unless I have a large mediastinal mass or a large mass in the lungs, there is no reason to give intravenous contrast in the chest. So neck, all scans are with IV contrast. Chest, the vast majority are plain scans. Abdomen, pelvis, except for CT KUB, they are all done with intravenous contrast. So just to get an understanding.
So again, in the chest, lymph nodes are better seen with contrast. Did you say no?
But you can see them well without contrast as well. So only if the lymph nodes are really enlarged. I mean, so in the earlier days, we used to give IV contrast because the resolution was not good enough to allow us to differentiate, for example, the innominate artery from a lymph node or, things like that. So in the hilum, whether it's pulmonary artery or lymph node, we were not able to tell on a plain scan. Today on a plain scan, you can make all of these out. The only time you give contrast is if it's enlarged, then you want to know if it's necrotic, non-necrotic, what does it look like, then we give contrast.
Yes, sir.
Sir, in case of colon, if you are suspecting a growth in the colon, then very often we have the gastroenterologist saying that you get a PET CT because we are suspecting because you've got melena. And they also ask for colonoscopy. Now, very often the PET CT tells us that, okay, there is lesion which is suspicious and it looks more in favor of malignancy and do the biopsy. But colonoscopy, does it really add to the findings of the PET CT? And would I do a MRI with contrast or PET CT first for a colon cancer?
If you have a suspected colon cancer for whatever reason, the first
colonoscopy
is colonoscopy with biopsy. If the biopsy is negative, there is nothing further to be done. If the biopsy is positive, then depending on what the malignancy is, you would have the next step. If it's a CA rectum, then you do an MR for local staging. And you may do a PET CT for distant staging, but it's not mandatory. If it's a CA sigmoid and descending, transverse, etc., then you would do a PET CT for staging. So rectum, anorectal is very different from colon cancer per se. So they are handled differently. But we don't do a PET CT for diagnosis. We do a PET CT for staging. Diagnosis is on colonoscopy and biopsy or sigmoidoscopy and biopsy or whatever it is. And that's that.
Sir, let me just put it into a proper perspective. My patient had a polyp. Polyp was excised under direct this thing. And then it turned out to be adenomatosis. And then it was asked for the PET CT and then also colonoscopy.
No, was it adenocarcinoma?
Adenocarcinoma.
Correct. But that's because a colonoscopy had not been done in the past, but you already have a diagnosis of malignancy. So then both need to be done, whether one is done today and the other tomorrow. There is no, it's just a logistical thing. Whatever can be done earlier is
So
done.
the point is, will colonoscopy give me something more than what a PET CT?
Yes, because PET is not going to pick up polyps or mucosal polyps in the colon.
Okay.
If you need to know how many more polyps are there, etc., that is the role of colonoscopy, not PET CT.
Okay. And sir, abdomen CT with contrast, chest CT with contrast versus HRCT for lymphadenopathy, for sarcoidosis and all that.
So HRCT is a term we use for the lungs.
Not for the lymph nodes at all.
No, that's a regular CT scan. So there is no connect.
So do I have to write down chest CT with contrast for lymphadenopathy?
You can write chest CT SOS contrast if an enlarged lymph node is found. That is the best thing to do.
Fair enough. Thank you.
So for gynec conditions, do you recommend CT abdomen, like for fibroids?
Ultrasound.
Ultrasound.
We do MR of the uterus for fibroids, for endometrial carcinoma, ovarian lesions. But these are done for very, very specific situations when the operating surgeon, so you've already made a diagnosis, you've now decided on a plan of management, and then there are specific questions to be answered. So with endometrial cancer, it will be what is the depth of invasion? Are there adjacent lymph nodes? With fibroids, it will be, there are so many, we still don't know the size properly. What is the extent? If it's a broad ligament fibroid, where exactly has it gone? So those kind of things, then you would do an MR, not a CT. There is absolutely no role of CT when it comes to uterus and ovaries, unless it's a malignancy, operated, and you're just doing a routine follow-up post-operative to look for lymph nodes or mental mets, etc. Then you may do a CT scan. But otherwise, it's all ultrasound, MR, ultrasound,
Same
MR.
for endometriosis or
Everything. It's just MR, ultrasound and MR.
Thank you.
Here just wanted to, a very common clinical situation will be a postmenopausal female who does not have any bleeding but has an endometrial thickening which is abnormal, and they will undergo a tissue diagnosis
DNC.
and DNC, and they find some malignancy. Then before operating, they will do a MRI pelvis just to stage locally, or will they have to do a PET CT also?
Oh, sorry. No.
I was asking you because...
No, so many people don't do anything even today.
Okay.
And that is fine, because you can, if the ultrasound doesn't show anything and your DNC has not shown malignancy.
shown malignancy.
If the DNC shown malignancy, then it's MRI pelvis. And these days, though not guidelines based, we're seeing a trend of both being done together on the same day. PET CT is also done.
Also done.
Because a lot of times now PET CT has become, if we can afford it, why not? Why take a chance? Why make sure we don't have anything else anywhere in the body? But it's typically only MR pelvis is done.
Typically if MR does not show any local mets, there is an unlikelihood of distant mets that you will find on PET. Okay.
So just to kind of put it in perspective, the common malignancies now where PET is almost always done for every patient is every lymphoma, because PET response is also part of management, all lung cancers, all colorectal cancers, and while breast cancer is not part of international guidelines in India, virtually every breast cancer patient also gets a PET CT done today. So now, in a way, it's guideline based and you would pretty much have to do it. Hepatomas, renal cell carcinomas don't show up well on PET, so we don't recommend PET in them. Ovarian cancers, gastric cancers, those, it's person based. In the sense, it depends on how the person has manifested, what the disease is. So then those decisions are taken. But at least remember, lymphoma, lung, breast, colorectal, a PET is done in almost every patient.
Yeah.
Hello. Yeah. Sir, regarding different aspects of PET, what is the difference between a contrast PET and a non-contrast PET? Second question is...
Okay, no, take one at a time, sorry. I forget, I'm going old now. So, contrast PET is like contrast CT. The contrast is, so when somebody says contrast, it is about the CT contrast. It's the PET is anyway the dye that has to be injected. You can't do a PET without the FDG. When somebody says contrast PET, it means you're giving iodinated contrast like you would do in a CT abdomen or CT neck or CT chest. And the point is, it's not always needed. So very often a CT scan has already been done 5 days ago. Then why do you need to again give iodinated contrast? In all lymphomas, we don't need to give iodinated contrast at all, because all you're looking at the activity of the lymph nodes. So in follow-up, we do a lot of follow-up PET scans for even lung, breast, colorectal. Unless absolutely required, we don't give iodinated contrast. But that decision is ours, not yours. So whatever you say, unless it is an oncologist or oncosurgeon who understands PET CT very well and has specifically written down, do a plain CT, whatever you all write, we will do whatever we want. So,
And so secondly, about how overestimates PET from the clinical condition, like?
Does PET lead you to wrong things?
No. I mean, everything has to be interpreted. There is a skill in that. There could be over-interpretation if somebody doesn't understand it well, but no, it's not an issue.
Thank you.
Thank you. Please come.
Sir, couple of questions. The first one is role of MRI in a perianal fistula, communicating fistula,
So, MR is a big modality for all anal fistula and anal conditions, because you can actually see the fistula very well. And many perianal fistula and fistula surgeons now don't see patients unless the MRI has been done, that too as per their protocol. They're all contrast enhanced scans and specific reconstruction, so you can map out the sinus, the fistula. It's a big thing. I mean, people do it. When we started about 10 years ago, I used to read each and every one of them. Now I have colleagues who are specialized in that, and they're very good at that. So I don't look at them, but yeah.
Has that changed the surgical success rate?
Yeah. So if you talk to somebody like Parvez Sheikh and people who only do fistula surgery, it's completely changed the landscape. Yeah.
The second one was that when we refer patients to sonologists often talk to patients and they tell them, ये ऐसा हो सकता है, ये diagnosis है, and it can be really disturbing for doctors. I'm not sure what is the medical legal aspect and whether sonologists are allowed to talk to patients, give them diagnosis.
He's asking, do you talk to patients?
So I will tell you that the older I grow, the more I talk to patients. And so I will give you an example. Many of you may know Dr. K.C. Shah. He's a surgeon now, not practicing. So Kishore Shah, I mean, he's my mentor, very senior. And when I just started in CT, my first CT was in that old HN hospital in 94, 95. I was 35, 36, very enthusiastic. So once a patient came, we did a CT for appendicitis. Patient asked me, is there appendicitis? I said, no, CT scan is normal. K.C. Shah came and chhadawed me, left, right and center. He says, why are you telling the patient? It's my clinical judgment. Even if your CT is negative, if I want to operate and I feel, because those were the days when we were not 100%, no, resolution was not great, we had this thing. He says, in this patient, I know the patient has appendicitis, I don't care what it is. You have to tell the patient, please talk to your surgeon, I will communicate it with the surgeon and things like that. So, for many years, when I was young, I would use that escape route, that sometimes I would say that machine is taking time, computer takes time to show the images, or to these days if it's cardiac CT and it's bad and you don't want to talk to the patient because they'll go outside and collapse, you'll say that reconstruction time of the AI takes time. Some rubbish you will say and you have to believe, right? You don't know. But when a patient asks a direct question, right, I cannot anymore, I mean, the older I got, the patient would look at me and say, "Tamne 20 varasno experience hai, tamne thodik to khabar pade." I can't turn around and say, "Tame tamara surgeon ne jaine mado hu emne baat kari." It doesn't work like that anymore. So today, in fact, it's reached a stage where, let's say that I'm doing a biopsy, right? A person has come, I'm counseling the patient, and the patient asks one fundamental question which 95% patients will never ask. But that person asks me, is the biopsy required or not? Right? And if it is not required, so very often if it's absolutely not required, I would have told the physician or surgeon in the beginning itself, this is not required, let's not do it, there are other ways, and that's done. Sometimes it's a plus minus. You don't do it, it's okay, you do it, it's fine, which means you respect the referring doctor's judgment and say, yes, I mean, if you think it's required, we'll do it, even if I don't agree with you. End of the day, that's your professionalism, right? But the patient asks that question. If the patient doesn't ask that question, I'm doing the biopsy, they will ask questions like, standard question is, when can I eat next? I've been fasting. It doesn't matter. Earlier it was only gujus and madus, now everybody. The only question they ask is, when can I eat? It's okay. But if somebody asks this question, is the biopsy required or not? I cannot turn around and tell the patient, go ask your surgeon, right? Or go ask your physician. I mean, I will say, listen, this decision has already been taken. Do you want to revisit the decision? And I'm telling you, 1 in 100 patients will say, yes, we are not sure it's required. Then I'll say, then let's not do it today. I will talk to your doctor, you go back to your doctor, and we will decide what is to be done. This is this, but when it comes to diagnosis, somebody comes and tells me that, what do you, asks me, I will tell them straight away today what the diagnosis is. If they ask me for treatment options, so if it's appendicitis and surgery, I'll say, obviously, go back to your surgeon, they'll do what is required to be done. But if it's a complex situation, then I have to tell them it's complex. Now, if it's a triple vessel disease and the person says, oh, so now I have to go for bypass, to bada cardiologist eva chhe, have to mane badu ravade nakhari des, nakhi des, that's the word they use. And I have to turn around and say, but you need treatment. The only question is who to go to, where to go, what to do. That now you figure out. Then they will say, but tamne to 25 varasno experience hai, sauthi best kon chhe? I will not answer that question under any circumstances ever in my life, right? Because I cannot do that, right? If there is only one person doing it in the city, like there was a time when only Prashant Chajed was doing e-buses, then it's easy. There is only one person doing it, please go there. Today there are 7 people doing it. So if they ask me, is this person doing e-bus in Reliance HN good? You think I'm ever going to say that the person is not good? How does that even work? You will always say the person is good. Or how can you tell somebody that the person is not good? So now we talk to patients, and in fact, sonologists are in a privileged position to talk to patients. That's how they establish rapport, relationships, and they make your life so much easier 90% of the times by discussing things, talking to them. And don't forget, in today's world, every sonologist, every radiologist who's going to practice till the age of 75, 80, after the age of 50, 60, when they're tired of all the commercial rubbish that goes on, the only way they will survive is direct practice from the patients with whom they have established a relationship, such that even if you tomorrow say, please go and do an ultrasound there, that patient will say, "नहीं, हमें 20 वर्ष थी आनी साथे जाइए छे, हमने बहुत सारू लागे छे, we are going to go here and do the ultrasound, do you have an objection?" And you can never say that I have an objection, because how can you, right? So that is why sonologists talk to patients, because they also know that in the future, these are direct patients, or these are patients who will be loyal to them. That is the advantage they have, and they use it, and they will use it, and they must use it. There is no question about that. That's a long answer to a short question.
Thank you.
Yeah, Kumar, when will we have our tea? Okay, Bamre, come. Before he goes ahead, okay, I'll ask you my question later.
CT abdomen versus CT enterography.
Ah, that's a question. So,
CT enterography, what is it and what are its indications?
So CT enterography is a very specific test that we do only when it is asked for as CT enterography. And that typically comes from a gastroenterologist or sometimes a GI surgeon, where the aim is only to evaluate the jejunal and ileal loops, sometimes the proximal colon. That's it. CT enterography is done using negative contrast, which could either be mannitol or just water. There are two ways of doing this. One is with a tube and the second is without a tube. Tubeless is when you just give a lot of mannitol and water and the bowel loops get distended, and then you pretty much do the scan so that you can look for subtle lesions in the jejunum and ileum. Whereas with the tube goes, the Bilbao daughter tube, which is used for small bowel enemas, goes beyond the DJ flexure, and then you actually inject the mannitol using a pump, and then you scan, because as the mannitol goes in, it distends the bowel loops and you can take scans. Which we do depends on the preference of the gastroenterologist, but 95% of all CT enterograms are done as tubeless, not with a tube, and they give good information, and it's pretty much the main indication is either a tumor or Crohn's or something like that.
CT enterography is versus colonoscopy. That means CT enterography is much better.
CT colography or?
No. So CT enterography is small bowel. Virtual colonoscopy is what you probably mean when we compare it with regular colonoscopy. But virtual colonoscopy had its moment 5-7 years ago. Nobody does it anymore, and it was only for screening for polyps, which screening colonoscopy is far better than virtual colonoscopy. Enterography is done because there is no way to see the small bowel. Even with capsule endoscopy, there is still a lot of limitation to what you can see with capsule endoscopy, the biopsies that you do. So CT enterography is a very common, we do almost one every 2-3 days. It's just a very standard way of distending the bowel and making an effort to see that the bowel is well seen. In the Western countries, many of them use MR enterography instead of CT enterography, especially if they have to serially follow up patients with Crohn's disease and IBD. That's the only difference.
Thanks.
Deepak?
So the different levels of SUV that we see in a PET scan, any clinical significance?
Yeah. So usually an SUV less than 2 means that the lesion is not active. Doesn't mean it's not significant. It could still be significant. For example, a renal cell carcinoma might be very obvious, but the tumor type is such that you may not have activity of more than 1.5 or 2. So it is in that context. But let's take lymphoma, for example, or lung cancer, for example. If you have an SUV less than 2, it means that, so let's say you have a lung cancer and you're looking at the lymph node, and the lymph node has an SUV less than 2, then it means there's no spread. If it says that the SUV is more than 4, then usually it means it is significant, and then you just have to look at the lymph node characteristic to decide in the chest whether it could be old TB or whether it's that. So SUV is not histopath. It only tells you what the activity level is. It doesn't actually tell you whether it's infection or tumor. So let's say you're doing a PO patient and you find a 15 SUV lymph node. What does that mean? Nothing. It just means that it is significant. This is the one lymph node that has to be biopsied, but is it TB? TB can be 15. Is it lymphoma? Lymphoma can be 15. Is it metastatic? Metastasis can be 15 as well. So SUV is only an indicator of level of activity, not histopath.
So at what level would you call the activity as significant?
Above 2.
Above 2.
Above 2.
SUV is basically a measure of FDG uptake in units.
Yeah.
Okay.
Standard uptake value SUV.
Hi sir, in continuation with the previous question, when you do CT abdomen with per-oral contrast, so you look at the small bowel as well, na? Means, do we need to specify enterogram or per-oral contrast is similar?
No, per-oral works, but what happens is it's logistics and time, etc. Right? If I have to distend the small bowel, then I need to pay a little more attention to how much water is being drunk, if it's water or mannitol, and then nowadays it's mainly water, and then time it well, things like that. If it's not really small bowel, if you're not worried about a malabsorption syndrome, or the studies being done, let's say for an obvious CA colon or for appendicitis or for a liver tumor, then my approach is different. I'm going faster. I'm not bothered about giving too much water. We may do it without any patient comes in, we may take the patient right away instead of giving anything to drink. So it matters. We just need to know why we are doing what we are doing. Yeah.
For terminal ileal lesions like ileocecal cox,
I wouldn't bother, because terminal ileum, whether you've distended the proximal bowel or not, you'll still see it very well. So I don't care. Yeah.
So no need to enterogram, no need.
Not for IC lesions, no.
Thank you, sir.
Okay. About intravenous dyes in CT scan. You said we use non-ionic dye now. What are the side effects that you still see due to the dye? Do you give a test dose? You don't give a test dose?
So no test dose ever, because negative test dose is not a guarantee that a person will not react. And a positive test dose is no guarantee that the patient actually would have reacted. So it's both ways. We just, typically you still see some nausea in patients, and once in a while you'll have somebody with urticaria, but the incidence of a severe reaction with anaphylaxis, patient dying, etc. would be, I guess, 1 in a million. So we've seen 2 severe reactions after we switched to non-ionic in the last 15 years, just, very, very rare. So they're really, really safe agents to work with. It's not a problem.
Okay. You spoke about in pyelonephritis, the arterial phase, the venous phase. So just explain to us what is triple phase CT and where is it used?
So triple phase CT is a term that pretty much came out with in the context of liver tumors and pancreatic tumors. There are actually it's 4 phases. Okay. It's a plain scan, an arterial phase, a venous phase, and a delayed phase. In some instances, it's plain, arterial, capillary, and venous. In the liver, it's plain, arterial, portal, and venous. So it depends on where we are doing what. Now, some of you may have heard 4D CT of the neck, which we do for parathyroid nodules. It's the same thing. It's just the same 4-phase or triple phase CT that we do, it's a plain arterial, venous and a delayed done exactly after 10 minutes. Because you measure the values and then you see the curve and then you see what is happening. So it's just a question of tailoring it to the indication. And it's all done either in the neck for parathyroid or in the liver or in the pancreas. These are the areas where we do what we now call just multiphasic CT. And the number of phases and when those phases are timed will depend upon the indication.
So for example, in a hepatocellular carcinoma as an indication, what will the phases help with?
Plain, arterial, portal, venous and delayed. We do 5. The plain scan tells us whether there's calcification. Arterial phase tells us about hypervascularity, which most hepatomas have. And if they are not hepatomas, then other tumors have other forms of vascularity. The portal phase tells us and shows us the portal vein, so we know where the thrombus is, what is the relationship with the portal vein. Then the venous phase is the phase of the hepatic veins, which tells us about that, also tells us what is the washout of contrast from the tumor, how are they behaving. And then you do a 5 or 10 minute delayed, which again tells you whether there's contrast being retained within the tumor, which happens with cholangiocarcinomas, hepatic adenomas, etc., or whether everything is washed out, etc. And sometimes if you also want to see the kidneys and ureters at the same time, then that delayed phase helps. So it's actually 5 phases, not just...
So it's called multi-phase?
Meaning people use triple phase, we just know what they mean depending on the indication. But invariably you'll end up doing more than 3 phases for sure. So.
Okay, before we go for the tea break, tell us, just as you said, about 16 slices, 32 slices series. What is 1.5 Tesla MR? What is 3 Tesla MR?
So this is the strength of the magnet, which is inside the MRI machine, right? So the first MRI that ever came into India, which was at Breach Candy, it was the second one that Viral Shah had brought. The first one was in Mass in Delhi. But Viral's order was the first order, whatever. And that was a 1 Tesla. Then the second MRI that came into Mumbai, which Dr. Nayan Shah had brought in, was a 0.3 Tesla. It was a permanent magnet. So you have permanent magnets and you have superconducting magnets. Permanent magnets are very heavy because it's just a permanent magnet. It's the whole thing is a single magnet, right? They weigh about 11 tons, 12 tons, 13 tons, etc. A superconducting magnet has the magnetic possibility, but only when it is cooled by helium and the electric current is going through it. So those are not as heavy. They would be about 1.5 to 2 tons. And when you switch off the magnet, the machine, which you never do in real life, but once it is done with and you are sending it away, you actually switch it off, then there is no magnetism associated with a superconductor. So superconductors today are 1.5 Tesla, which is the strength of the magnet, or 3 Tesla, which is the strength of the magnet. Permanent magnets, which also used to be open MRIs because you have a larger bore, used to be 0.2, 0.3, 0.5, and they reached up to 0.7. Some of you may remember that Dr. Amit Manyar of Shriji had once got a standing, moving MRI.
Non-claustrophobic.
Yeah, and you could also do it in the erect position and things like that. So that was a 0.7 Tesla MRI. But today in the city of Mumbai, we don't have a single permanent magnet or a low Tesla MRI. Everything is 1.5 and higher.
So between 1.5 and 3, what are the differences? Why is 3 better?
So it's about resolution. The higher the magnet, the faster you can scan, or you can, so it's about trade-off between time and resolution. If I spend more time on a 3 Tesla, I can get higher resolution, or whatever time I was taking on a 1.5, I can do it faster at the same resolution. So we may decide to do both, do it faster but also increase the resolution and things like that. In the brain, for example, today, the resolution that you get with a 3 Tesla for the same time that you would spend on a 1.5 is so much better that most brain scans you'll find neurologists, neurosurgeons almost always just prefer a 3 Tesla. But when it comes to, let's say, a spine MRI, lumbosacral spine, dorsal spine, for TB, for disc disease, facet disease, it doesn't matter because that increased resolution doesn't give you much extra, provided the 1.5 Tesla is a new machine in the last 5 years or so, because there are some older ones which are quite bad. But cervical spine, CVJ, you would prefer a 3 Tesla almost all the time. When it comes to abdomen, liver, pancreas, pelvis, etc. Pelvis, I would always prefer a 3 Tesla. Liver and pancreas, sometimes it's better to have a 1.5 because you can go faster. And in many patients who are sick, breathing problems, etc., then it's a good 1.5 is good enough. For the joints, it depends if it's hip or a knee, then a good 1.5 is good enough. But if you're doing wrist, finger, and there are very few hand surgeons, right, about 5 or 6 of them, all of them will want a 3 Tesla to the extent that if the 1.5T scan has been done just 5 days back, they will make the patient repeat it at a specific center. So it's all variable. Everyone is moving towards 3 Tesla. Every new machine installed by any diagnostic center, at least within the limits of Mumbai, not in the far suburbs, is a 3 Tesla now. But a 1.5 can do 80% of the work of a 3 Tesla even today. It's not an issue.
What is the cost difference between 1.5 and 3?
Quite a lot. A 3 Tesla fully loaded with everything within today is about 12 to 15 crores. A 1.5 Tesla would be about, a similar fully loaded would be about 7 to 8 crores. Everything's become very expensive. There is a new cess that the government introduced during COVID, 3 to 5% on all imported equipment, which has not been taken away. So that adds to the cost. Helium has become very expensive. Earlier, helium used to cost 5 lakhs. Today it costs 1 crore.
Oh.
And that's because of Ukraine. So most helium comes from Russia. And somehow one has shut down. Now there's only one person who's selling, and now the Russians have problems distributing, and the Ukraine war has also created a lot of problems with a lot of things. So a lot of prices
have you been able to pass on the cost escalation to the patient?
Yes, we have. Some of my colleagues are not fortunate enough, depending on the competitive environment, and then they have to just hope to do more patients, run 24/7. It's not easy, but yeah, we've been a little more fortunate.
I think we'll take a break now and we'll gather again after the tea.